Number one, child labor is something that is natural, and therefore we don't expect that everyone gets a complication. In fact, most mothers do not get complications. But in some cases, we do, yes, have women who things don't go as we expect. And some of the challenges that they may have are either related to mom or to baby. So based on where you lie, okay, let's not say you are mothers of nations, complications don't reach you. But if a woman out there has a complication, we baby. So how we look at that is we monitor during the labor itself. And complications start from just how long the labor. So for example, if your labor kicked in, and by labor kicking in, we mean active phase of because in some cases the contractions start and they're very minimal, and then as ladies we start counting. My labor started yesterday or the day before yesterday at 2 p.m. Yet it was still just that your body still preparing yourself, or what we call latent phase of labor. So that's one thing that we count. So once you enter active labor and you start seeing you're going 14 hours, 16 hours, 18 hours, 20, 24 hours, then we know you're in trouble. So we prefer labor happening between 10 to 14 hours. If it goes very long, maybe up to 18 hours. And as doctors, we're really keen to make sure that that is the time frame, because anything beyond that, you may end up going into weakening your muscles too much, or the baby getting tired. But most often than not, it is mom getting tired and baby getting tired. And then because of the continuous stretch of the abdomen, you may also get other issues such as a rupture of the uterus or perineal tears. So basically, we look at that quite critically. Then we also look at short labors. And I know we really proclaim them that my labor lasted 30 minutes, my labor lasted 1 hour, my labor lasted 2 hours. In medical terms, that is also a complication. We call it precipitate labor, where the time from active labor to delivery is too short. And why that concerns us in the hospital or wherever that may be is because your body was not complaining about short labors or precipitate labors, in case you've just joined us. And short labors tend to come with extensive tears, or baby is also not very ready for life on this side, because as contractions happen and labor continues, what happens is that it prepares the mother and the baby psychologically for labor. So we're also very concerned when that happens, because they tend to bleed a lot post-delivery, and of course there's that issue of tears. Yeah, so that is on mother. Okay. The other thing is that the bone structure of the mother may not be very wide. So if the bone structure is not very wide, the baby's in proportion to the baby's head. So some people with small babies are able to deliver normally, and then in the second or third time, if the baby is bigger, let's say your first baby was 2 kgs, 2.4, then the next baby is 4 kgs or 3.8 or whatever, then the baby's head may not fit in the pelvis. So that we'd call that cephalic, which is head, pelvic disproportion. Okay. So that may happen if the baby's head tilts badly, or just the size of the pelvis and the size of the head are not compatible. Okay. So if that happens, no matter how long you stay, it will not deliver, and we call that obstructive labor. Or if we force the head to come down, it usually may stress the baby, or sometimes it can stress the baby, and the baby comes out having complications. The complications, I mean birth asphyxia or meconium MSL. Meconium means because of the stress of pass stool in the abdomen, and that stool enters the amniotic fluid. And then as they are in the tummy, they swallow this fluid. Usually not a problem, but if they swallow it and it goes to the lungs, that is the issue, okay? So we call that meconium stained liquor. So if they end up aspirating it, then that becomes the issue. So we try not to, we try and make sure that the head and the pelvis is well proportional so that you don't get, baby doesn't get such issues. The other thing is that if the baby's head is too big and labor continues happening, and especially rapidly, it will pull open the pelvis. Like literally, it will just pull open the pubic bones. So end up with a lot of pubic pain later on the bones itself. Remember, in pregnancy, the ligaments weaken to allow labor to happen. So it is a physiological thing, just that it can be very painful afterwards. Okay, so that is on the mother's side. And of course, there's hypertension and diabetes, but we'll discuss that if someone has a question, but it's a bit more in depth. On the other side, on the baby, we check if the baby is doing well. How do we know if the baby is doing well? We check the heartbeat of the baby. Usually in labor, you'll find that they keep coming to listen to, okay, is the baby okay? Okay. And they listen with a fetoscope or a device that allows us to hear the heartbeat of the baby. And then we tell you that baby is still doing okay. Sometimes you'll find they'll tell you the heartbeat of the baby is too fast, the baby is not coping with labor, or they'll tell you to turn to one side or turn to the other side, or take a drink or take food, and then they test again to see if the baby's heartbeat has stabilized. So that's one. The other thing that we use to monitor how the baby is doing is the head itself, the lines on the head that we check to see if they're cramping. So the bone skull should look like this. If when we check, we see that it started going like that or molding, and then something else we call caput, medical terms, but generally we want to see is a baby's head being squashed by the pelvis. If that's not happening, we allow labor to continue naturally. So it's because of these reasons that we really, really want to tell you to please be with a healthcare practitioner who is licensed, who knows what they're doing, who has been trained while you're in labor. You can labor from home if you're next to the hospital and you can be rushed if there's a complication. But please, please, we caution you, go to hospital. Let there be a nurse who's trained, a midwife that is, let there be a doctor or a gynecologist based on what is around you, and be monitored during labor. So yeah, that's the long and short of complications. They don't happen often, but when they do, they can be quite catastrophic. And that's why we say prevention is cure. It's better to be prepared and mitigate it than to just go in blindly. Yeah. But God is good and He protects most of our mothers, all of our children. And if anything happens, we know that He must have had a reason. So that's what I would say. Dr. Mercy, if you're here, you can proceed.
Thank you, Dr. Jemima. I think that was very eye-opening to most of our mothers. Just to add on, I think some of our mothers need to know that some of these can be prevented even earlier, these birth complications. We have mothers who are what I would call stubborn, though Pastor Reed doesn't want us to use the word stubborn. They're active. They go for visits and the scan is telling them the baby is big. Maybe they're breech in that they're presenting with the bum first or the legs first, and the mothers are insisting to push. They're like, no, I want to push my baby. The baby is big. The presentation is wrong, and they're being stubborn. So just to encourage mothers, sometimes you for the good of the baby and your life, it's good maybe you seek further consult from another doctor, but to behave and just like other doctors are saying, delivering a cesarean section is not the worst of all, because we need a healthy mother and a healthy baby. So if the doctors, the gyne checks you and says you're not able to do a vaginal delivery, please listen and don't be stubborn, because so many mothers have lost babies and got complications from being stubborn. Just yes, that's bad.
I agree. I agree. And it can be quite challenging when you have what we call a well-informed, misinformed mom, because no one wants you to have a cesarean delivery unless it's really required. But I say that a cesarean delivery is not a death sentence. Yeah. And even an earlier delivery is not a death sentence, which means you may have wanted to go up to 40 weeks, but you have an issue. For example, you're 37 weeks, you have diabetes or pregnancy or hypertension or pregnancy, and it's complicating. The baby looks like they're growing bigger than they ought to or smaller than they ought to. The scans, the blood vessels are not pumping well, or we call them the Dopplers are not good. And we suggest that let's try and get this baby home earlier instead of waiting in the womb. So we do this to try and protect the baby, and especially if you have diabetes or pregnancy, and most of them have very big babies. You find babies of 4 kgs, 4.5 kilos. These are very big babies. And typically the mother would have had I don't say glycosuria, but would have diabetes of pregnancy. So diabetes of pregnancy clears immediately the mother delivers in most cases, but it has to be picked because that big baby, one thing is that if they don't get sufficient sugar immediately they're born, they're already used to a very high sugar, can I say, high sugar environment. So as you're struggling to get milk and not get milk, and those first few minutes when the baby is still just being born, if it's a complication that had not been picked, then it will result in an issue. Yeah. So because of that, we usually say let's get these babies out earlier. Let's check them for issues of calcium, magnesium, have electrolyte imbalances. They usually have respiratory distress in the abdomen. So all these factors would make us say, let's induce the baby. But you may find most moms refusing an induction because, well, it is not natural, and well, this and that. So we don't say that you have an induction of a cesarean because we want as doctors, or we are trying to get your money so that we can be paid more from a cesarean. I mean, some of our people may do so, but generally it's usually to help mothers. Yeah. So please bear with us. Or you may find some mothers insisting I want a cesarean section, and yet they're very eligible for a normal delivery, and we're telling them, imagine try a normal labor because you heal faster, it has better outcome if there's no complication, and they're still insisting, no, I want a cesarean. So basically, trust your doctor, trust your midwife, and just be very open. The most important thing about delivery is a safe mother, safe baby. That's it. That's all we care about. Whether it was an abdominal delivery, a vaginal delivery, a vacuum delivery, it doesn't matter. Yeah, yeah. And then I've had doc talk about breech delivery. Yes, there's some breech deliveries that can happen vaginally, but that baby has to be very small within the normal ranges. Why? Because this is a very sad story, and I hope we don't have one of those mothers here. This is a very sad story of a mother who had not gone for clinic, sadly, and then ended up in hospital in labor already. The baby had halfway passed through. So what happened is we have, yes, maneuvers to try and get the babies out, but as the maneuvers were happening, Unfortunately, the head was bigger than the pelvis, and because of how the baby had sat, it was positioned wrongly. I tell you this with a lot of sadness in my heart, but that baby was delivered minus the head. And it was one of the most heartbreaking things we have ever seen in the hospital. So when we tell you, please just let's not do breech delivery vaginally, it's not because we want anything, it's because of what we have seen when things go wrong, and sometimes they can go wrong. So yeah, Mercy or Belinda, whoever may have a question.
Thank you so much, Dr. Jemima and Dr. Mercy. I have questions already, but let me start with this one. What is the maximum weight recommended for a mother to deliver naturally? Because yes, we are believing God for supernatural childbirth, but I am not a doctor, and I have tried to convince these mothers to trust doctors, and they have failed to trust what I'm telling them. Now, our dear doctors, please tell these mothers what is best for them.
Dr. Mercy?
Okay. What I would say, it's not one shoe fits all. You have to consider both the baby's weight and the mother. Some women have a small pelvis, and the baby is quite big, and then some ladies have quite a wide pelvis, and compared to the baby's size. So it's not one shoe fits all. We can't tell you that 3.5, yet you find a woman has a narrow pelvis, they may not be able to deliver that child. So they have to examine both you and the baby. There is no set weight that every 3.8 can be pushed by every mother, every 4 kilogram. So it's both the mother and the baby have to be examined to see if it's a fit. Maybe Dr. Jemima can add.
I totally agree. Medically, we say 2.5 to 3.5, but based on race, mother, pelvis, it really is based on so many things. So, especially the first time, it's very hard to tell until we're actually in labor looking at the baby and looking at the mother. So, we say that every first time is a trial of labor, because we have to really assess to find out. But the weights that, of course, will cancel out. For example, anything above 4.5, even with the African body, even with a wide pelvis, we really take caution unless that mother has delivered prior and they've delivered big babies. So it's really based on the patient, not based on the textbook, because sometimes mothers and children don't read textbooks.
Wow, amazing. What are the side effects of family planning, FemiPlan, and is it true it has risks of breast cancer? What would you recommend for a breastfeeding mom?
I'll take that because I'm very passionate about family planning. I would not recommend an estrogen-based contraceptive that is like FemiPlan, as you've mentioned, during breastfeeding. Reason being that it actually reduces the amount of breast milk because it's predominantly estrogen. The other thing is right after labor, women have certain risk factors for developing a clot. Some of them being the pregnancy itself, the fact that they stayed for long in hospital, and then after that, the bleeding post-delivery. So if you now add an extra one, which is the estrogen-based contraceptives, such as the pills, then you actually are likely to get that lady to get a clot, and then that clot can go into the lungs, and in very many complications can follow after. So no estrogen-based contraceptive during breastfeeding. However, there's a caveat. If it's after 6 months, you're not breastfeeding anymore, and you've started weaning, you're out of that phase where we say you're very high risk, then that's fine. You can take the pill. The risk factor that you mentioned was breast cancer. Yes, prolonged exposure to estrogen can give you breast cancer. And by prolonged, we mean you have been on these pills for maybe 30 or 40 years, and especially after menopause, because the women who keep taking them to protect them from the effects of menopause. So in that case, then you are likely, or if you have those genetics of developing breast cancer, you can develop breast cancer. But not everyone has the genetics that carry breast cancer, the risk factors for breast cancer. So you need to look at your family line. Other than that, it's actually very protective. It protects you from uterine cancer, it protects you from many other ovarian-related cancers, of fallopian tube cancers. But when it comes to breast cancer, it has been associated as a risk because of prolonged exposure.
All right, thank you so much. Can one be treated from endometriosis? I guess I'm reading it the right way.
Oh my goodness. Yes, if someone has been suffering from endometriosis, it is treatable. It is treatable if caught early and if treated by a specialist. We do have specialists of endometriosis in Kenya. If you're in Kenya, we actually have both certified globally endometriosis specialists. You don't have to be in pain because of endo. You don't have to be in pain every time you get your periods. Please, it is manageable, and in some cases it can be treated. So we need to look at your scans. We need to look at your, and by scans we mean an endometriosis scan. That is a scan that's done by someone who's been trained to actually pick the disease. We need to look at your history, your response to the medications that we have, and then we have surgeries that are very good for eradicating and removing all the nodules that are present. So yes, it's possible to treat it, but it requires specialists. And I happen to have been mentored by two of the best specialists that we have in the country. So if you have an issue, please let me know. They usually offer free camps at some point, or if you have an HIF, or very reduced prices on that particular kind of issue. So if you do have that, please let me know. I'll also try and get them to have a discussion with us. They're quite busy, but they can offer us their time so that if you have issues with endometriosis, we can discuss them at length with them. So yeah.
Right, thank you so much. How can I reduce pain during intercourse? During pregnancy, the pain wasn't there. I think the psychological have worked on that.
Marcy?
First repeat the end of the question. If I just said the pain is not there anymore. So I got
The
lost a
pain
bit.
wasn't there before, so she thinks it's not psychological because she has worked on that.
But she has the pain now.
Yes, now she has the pain.
I think pain during intercourse is caused by different factors. It can come down to the lubrication. Is she having enough fluid? The gentleness of the man. Is she mentally ready? Or even she could be edemata. Some women get quite edematous down there during intercourse. So the man may need to be
Hi,
more
doctor.
gentle.
Thank you for today. My question is, I'm 6 months pregnant and I went for antenatal yesterday and they told me the baby is not lying properly in the stomach. Is there any possibility by the coming months the baby will change? Is there anything I'm supposed to do? Thank you.
Marcy, I'm not sure you are done answering the first question.
I think I was done. Maybe you can add on that before we answer this second mother.
Okay. Welcome, Mother of Six. Thank you for that lovely question. For the question of coitus, yes, as Dr. Dupa has said, it is based on very many factors from emotions to preparation down there. I think the only one I would add is also an infection. You can go to your gynecologist and they can check for you so that it is treated. Yeah. As for the question on the presentation of the baby or how the baby has sat in the body, please don't be worried. If it's the earlier months, 24 weeks, 28 weeks, even before 34 weeks, the baby can and do turn. My own daughter turned at 36 weeks. So she had been reached all along. So please don't worry about that. But you will require to be reviewed at again about 34 weeks just to see if the baby has turned or not, but it should not be a cause of concern.
All right, thank you so much, doctor. If you conceive at 7 months postpartum and the previous pregnancy you delivered by C-section, what are the chances of carrying the baby to full term and deliver safely? To be serious, but are there any complications or anything to worry about?
I think Mrs. Belinda is asking these questions directed to someone so that we know who's answering. But yes.
Yes, I'm asking for a mother who came to me, and I'm not a doctor, so I didn't give her the medical knowledge.
I know you asked Dr. Jemima or Dr. Adupa so that we know who's responding.
Oh,
yeah.
I think Dr. Jemima can respond this since you're a gyna.
Yes. Okay. So you were asking about having conceived within 7 months post-delivery, especially a cesarean baby. Yes, you can deliver safely, usually without complications. It's what we call a high-risk pregnancy, which means we don't want you to go into labor at all. And once you start feeling like you have contractions and things like that, we will stop you from breastfeeding usually. And then we will also schedule your cesarean section slightly earlier so that you don't go into labor because of the scar integrity. So we're not so sure if the uterine scar can hold if you start contracting. But otherwise, usually a similar pregnancy to all others without many issues.
Undergone ovarian cystectomy, heal and it never appears again. How does it affect her fertility? Dr. Mercy?
I think this is the best question for Dr. Jemima.
Okay, Dr. Jemima, can someone who has undergone ovarian
I'm not getting you well, but are you asking about an ovarian cystectomy?
Yes.
And
can it heal and it never appears again?
I usually, typically, yes, unless it's something like an endometriotic lesion which hasn't been removed completely. Usually cysts don't recur. And when they do, we observe them and see if they're physiological or just pathological. But especially if you've done surgery and they've checked and it was something benign, they go away completely. So it shouldn't be an area of concern. But need monitoring by your doctor, and your doctor will guide according to the patient. Because as I said, they don't treat textbooks.
And does it affect fertility?
A cyst being removed does not affect fertility too much, but an ovary being removed completely will affect your fertility. So if it's a big cyst, we will do a test to check how many viable eggs you have. So it's a test we call AMH, just a blood test to see how many follicles are still active, and it's a range. So it won't tell us 200,000, but it will tell us this lady is still highly fertile. And then post-surgery, we will check again and see if it has been affected. But a cyst that is simple, benign, when it's removed, it doesn't affect fertility so much because it's removed. That a cyst has its own bag. So when you just touch the bag and get it out, you leave the rest of the ovary looking well. So it's fine.
All right, thank you so much. A mother is concerned her EDD was 2nd December and she has no sign of labor. Is there an issue? Dr. Mercy, yes, please.
So the EDD depends on, was it an EDD by the scan? Is it according to her dates? So all that matters, because she could be using an EDD of
23.
But also today is 5th, so it's 3 days. So some pregnancies, EDD is usually 40 weeks, but some pregnancies go up to 41 weeks, or even usually we let them go up to 41 weeks so they can go up to 42. So I think it's still safe. Better at peace for now.
All right, so Dr. This to that, is it normal to give birth at 36 weeks or they have to be 38 weeks and above?
36 weeks is preterm labor. Usually we do 37 and above. In early, yeah, but we wouldn't want you to give birth below 37 weeks. Here we count 37 usually. Is the mother in labor or she's already given birth?
That I do not know. It is an anonymous question.
36 is not term yet.
All right, thank you. Dr. Jemima, how do I treat HPV sores?
HPV sores typically are treated by, it depends on where they are, how big they are, in which type of HPV it is. So if it's on the cervix, and HPV has been noted, we can do a cone biopsy, which is remove that area, or cryotherapy. But if it's on the vaginal walls, on the labia, we tend to boost your immunity and then check again after 6 months to see if it's treated, and then annually to see if it cleared. But if you're talking about genital warts, which are also caused by HPV, then we have a way to chemically burn them using what we call caustic pencils or some type of chemicals that we use along the area that are very harsh. So we cannot do that in pregnancy, but outside pregnancy, we typically treat them. But if your immunity is good, HPV tends to clear. It has to be monitored because, as we know, HPV can cause and does cause vaginal and cervical cancer. So it's something that has to be really, really monitored. And then if you've seen HPV, there's something we call HPV typing, where some cells are taken that will determine which of the many variants of HPV you're carrying. So if you're carrying the more high-risk ones, we'll probably tell you, let's cut them out through a minor surgery, either using lip or using cryo or using any other excision method within the hospital.
All right, thank you so much. Dr. Mercy, what is referring gives influence?
So there are various things. I can't point to just one. Sometimes it comes down to the immunity of the person, hygiene. Some people use a lot of things down there that change the pH. But usually these yeast infections come when the pH of the vagina down there changes. The people who use soap, who insert there are those vaginal washes and whatnot. So things that will alter your pH down there. Sometimes it's the type of underwear. There are some underwear that are maybe like silk when you overuse those. So I think the mother needs to change to using cotton. Use just water to wash down there. You don't need to use soap to wash your vagina or insert those things. And also your general immunity matters. Yeah, maybe Dr. Jemima can add.
Definitely, Doc, I agree with you. And just drinking things that have probiotics, the yogurt, the natural yogurts, fermented milk can also help. But all the lifestyle changes you've advised are definitely what we do.
So much. Is there a cure for fibroids other than surgery? Do they grow big with time? What are the risk factors? Can they cause infertility?
Fibroids, fibroids can be treated in many ways. To guide someone who may not know what fibroids are, they're small benign tumors that grow within the uterus, and are very common in the African origin and Hispanic, but most commonly in the African region. They can cause infertility based on where they are. So if they are near the fallopian tubes, they will block the sperm from reaching the egg. If they're in the lining of the uterus, then they can also block upwards streaming of the sperm, or they can cause miscarriages because of creating a harsh environment for implantation. But those that are in the middle of the uterus tend to not cause infertility, but they'll cause issues when they become really big, because now they start lying on the ureter and causing backflow of urine, and lying on the rectum and causing constipation and such like issues. But mostly the most common effect when you have fibroids would be bleeding. Bleeding is what we see the most, and very painful periods. Now, the treatment modalities are many. We say medication can be used, but that medication is very strong to the body, because it causes a pseudo menopause, and can only be used twice. So you find that it will shrink the fibroids, and once the medicine clears from the body, after about 2 or 3 years, you expect that they'll grow again. So we usually do this before surgery if the fibroids are too big, but more often than not, we will just go straight to surgery. There's also things such as uterine artery embolization, which means we block the blood supply to the fibroids, but as we're blocking the blood supply to the fibroid, remember we are blocking also the blood supply to the uterus, and sometimes also to the ovary that gets a bit of its supply from the uterine artery. So that can cause infertility. And once the arteries find another pathway to get to the uterus, the fibroids can still grow back. So it's not cast in stone that has cleared. When it comes to surgery, there are two types. We can just remove the uterus, the fibroids, or we can remove the uterus, and we can access it either via camera or actually cutting the entire abdomen open. So there are very many ways to help out. If the one that's causing a lot of issue is the small one, or the smaller ones are the lining of the uterus, if in case the issue is infertility, then we just put a camera through the vagina, remove that particular one, and come out. So there are very many treatment modalities for fibroids.
that it's now not there anymore. Someone is 40 years and above, and they're struggling to conceive either the first child or second or third, fourth. Is there anything they can do about it to balance the hormones or whatever is not right?
40 and above is a tricky space to start looking for babies, but in the age of medicine where we are, it's very easy to get a baby. The issue may be perhaps not using your own eggs if you had not stored them prior, or if the quality is not good. So if the issue is that the quality is not good, we can do IVF with another person's egg, or with your eggs but carefully chosen. If the issue is a husband, now we can actually pick one egg and fertilize it with one sperm and then implant it on the mother. The other modalities such as IUI, and also just giving medication to see if we can trigger more eggs to be released. So yeah, there are ways to get these children. Yesterday I was reading an article where a 78 or 72-year-old lady had gotten twins. So it's still possible in this day and age to do a lot when it comes to women's fertility. That said, there's a lot of space of prayer. And at 40, you're still very fertile, not as fertile as you were when you were younger, but you're still fertile. So don't reach 40 and not use contraception thinking you're not going to get pregnant. You can surprise yourself that you're 48 thinking you've gone into menopause and yet you're pregnant. So yes, pregnancy can still happen. If you're struggling, please work with your doctor. You may just need the pills and you conceive, or you may need higher modalities and they're present. They may be slightly expensive, but they're present and they can be used to help you get a baby. And pray. There's always a space for God.
Right. This is the last one, I believe. I was told that there were no eggs visible during my ovulation when I was doing an HCG procedure. Is this possible? What is the remedy for low egg count?
Is this still the 40-year-old? Belinda?
Yes, I was told there were no eggs visible during my ovulation when I was doing an HCG procedure. Is this possible? What is the remedy for low egg count?
Yes, it's possible that medication was triggered. You're triggered by medication and eggs you don't ovulate, or the eggs are not visible. Sometimes it could be that the dose of medication you were given was too little, but mostly it's that the egg count has reduced. Unfortunately, if the egg count has significantly reduced, there's not much we can do. We optimize you with a higher level of treatment, such as IVF, and we'll give you very high doses of the hormones of fertility to try and trigger the eggs the little eggs that still may be there. If at all the eggs are completely not there, even with very high doses of medication, then you may require to use a donor egg, but that will be guided by your doctor. But before you get to that drastic measure, usually we change the dosage of your medication to see if you'll respond to higher doses. I hope that helps.
I believe it has answered her question. Thank you so much, Dr. Maima and Dr. Masi. Our time is up, and the questions that I have are also done. If there are any more questions, our doctors are in our group. You can stay in